Hi, everyone. This is Professor Widener. Today in Chapter 8, we're going to talk about diagnostic and screening test reliability and validity. When we talk about the definitions of screening, basically what we're doing is we are taking people who don't have any symptoms of a condition and we're testing them for the disease or possible health condition. Testing consists of screening and diagnostic testing. Sometimes they are the same thing as secondary prevention, and they're a critical component of surveillance systems within our healthcare system. Screening can also be defined as the presumptive identification of unrecognized disease or health condition within a population by performing a test, an examination, or other procedures. It's important to remember the intent of the screening test, and it's basically to identify disease in a population that have no diagnosis of that disease. And some common tests you might be familiar with are blood pressure measurements, skin measurements, skin assessments for melanoma, hearing or vision tests, an annual tuberculosis test, an amniocentesis, or a blood glucose level. Sorry about that. So screening program essential criteria. So we want to make sure that the screening tests we are doing are actually working. So what we want the screening test to have is a high sensitivity and specificity. We want them to have a high positive predictive value. And we want the disease that is focused on the screening to be sufficiently serious enough that if it's found, it can cause significant disability, fatality, discomfort, or financial cost. When we're talking about screening tests, they all have the potential for legal and ethical issues. There's concerns for confidentiality and privacy. There's the potential for psychological issues related to the screening tests. So whenever we're deciding if we want to do a test or not, we must consider the risk versus the benefit to the group that we're screening. The test should be simple administration with interpretation. They should be safe to administer. And the test must be acceptable, as in not cause the patient significant discomfort or pain or psychological risk. Diagnostic follow-up and treatment services are available for a referral. So what that means is that if you get a positive screening test, you have the ability to refer them to someone to help them deal with the disease that was found. So when we're talking about testing validity, we're talking about a valid test that has the ability to detect the disease or health condition that it was meant to measure. Validity distinguishes between those with disease and those who do not have it. So if we're doing a test to test for colon cancer, we want to make sure that that test actually tests for colon cancer and not for like diabetes. So we want to say what we're testing for is actually what we are testing for. So that's important. So when you look at sensitivity, that is the ability of the test to correctly identify those individuals with the disease. And there's the formula there for that. And specificity is the ability of the test to correctly identify those that do not have the disease. So if you look at those tables and figures in your book, they will give you a little bit visualization to help understand that a little bit better. When we're looking at specificity and sensitivity terminology, these are some of the terms that are used. So you can read through those and just be aware of them. When we're talking about testing validity and the screening, the sensitivity and specificity dynamics, what this means is that, so if you hear that a test has a 90% Sensitivity, that means that 90% of the individuals screened by the test will have a true positive result, with 10% having a false negative. 90% means that the 90% of the people without the disease will have a true negative, and the result will be that 10% will have a false positive and be wrongly diagnosed with the disease. When we're looking at the positive predictive value, we're looking at a component of sensitivity. So sensitivity measures whether a test is positive in an individual who actually has the disease, while the positive predictive value is a measure of the frequency with the test results represented the correct identification of the disease among those individuals screened. It's a population screening, not an individual measurement. Positive predictive value is the portion of the individuals who test positive who have the disease among those tested. Positive predictive value is dependent on the prevalence of the disease within a population. So what that means is that if there is a higher prevalence of the disease, there will be a higher positive predictive value. Negative predictive value means that it is the proportion of individuals who screened negative who do not have the disease. As the prevalence of the disease decreases, the population of people who have this screening test, the negative predictive value will increase. The positivity rate is simply the number of positive test results out of the number of tests that were administered. This, I think, gives a good example of, I think it's just a good example to see all the different rates, the specificity, sensitivity, and the predictive values of the Zika virus during a outbreak in Singapore, and how you can see how it was, all the different numbers looked. So why are all these numbers important? As advanced practice nurses, why do we have to be familiar with all these things? And the biggest thing we need to know, we need to understand about these screening tests are that we can talk to people about their diagnostic sensitivity, their specificity, their predictive values, so we can educate and counsel our patients regarding the value of the test or the measure to actually detect disease or a health condition. So you want to be able to intelligently talk to people about why these are important. And you also want to be able to make recommendations based on your patient's health conditions. You may recommend someone, you know, who is 45 having symptoms, have a screening colonoscopy, but then you may have an 85-year-old who doesn't want screening colonoscopy anymore. You can explain to them the risks and the benefits and what it will mean to them, but ultimately the job is to educate them so uh, they know the information and can make an informed decision. When we look at testing interpretation, screening and diagnostics tests can either be binary, which means there's one or two results, either negative or positive, or a continuous test. A test that produces negative or positive results would be an example of like a colonoscopy or a mammogram. Either you have the disease or you don't. Continuous measured tests with continuous variables are heart rate, blood pressure, and glucose. What that means is there's not really any specific negative or positive results, but we see the trend over time. With and that's what this next point says. With continuous test measuring, at some point, one can establish if they have the disease or not. Typically, we don't diagnose high blood pressure off of one blood pressure, but several blood pressures over a period of time. Simultaneous testing uses two tests for a disease at the same time. There is a net gain in sensitivity, but there is also a net loss in specificity compared to either test administered alone. So you can check this out. If you check out Exhibit 8.5 on page 98 of your book, it'll give you an example of the net results for spontaneous testing. So test reliability, we want to make sure our tests are reliable. So reliability is the consistency which with a test accurately measures a characteristic over time. It also is the test result of is dependent upon consistent procedures for test administration and specific criteria for administration. So I thought this graphic was funny about the smell tests because is it reliable or is it not? Just a funny way to think about reliability. Some of the terms associated with test reliability are listed here. I'm certainly not going to read them all to you, but one to know for sure are the first two. You hear those quite frequently. Is retest reliability. That means if you take the test and you take the test again in another period of time, you will get the same results. So the more you take the test, you get consistent, reliable results. Another thing is called inter-rater reliability, which means this is a consistent correlation of two tests when they're compared to two or more individuals within the same sample. How you'll hear this sometimes is that you'll hear inter-rater reliability as if a form, like during an interview, if the person in the interview has consistent results, that will show that there's consistent inter-rater reliability if each person has consistent results. The first two are really the most important to know right there. And the last thing we're going to talk about this is test reliability. And the test that we use is called the kappa statistic. It is used to evaluate inter-observer reliability. The kappa statistic is the measure of the inter-observer agreement when compared to the expected level of agreement, or if it's done by chance. So you will not have to calculate a kappa statistic, but just know that that's what it measures. And I thought this target example was a good way to show the difference between reliability and validity as well. So thank you, and this concludes this chapter's lecture.